Welcome to RealPen's discussion of counties. We think counties are key to applying healthcare best practices. An overview of our discussion is, first of all, an overview. Second, data expanding, individuals supporting best practices, individually focused teams, relevance and action steps for all county population levels. Welcome aboard. This overview sets the record straight. Counties are a fundamental unit of local government in the United States. Administrative divisions within the states provide essential services, crucial role in addressing community needs, infrastructure, public safety, healthcare, and economic. Directly ties the knot to healthcare and best practices. A perspective that seemed important was how many are there and where are they, and the map tells us the story. 3,144. You can just imagine looking at that map, the level of variance across those counties. Putting some information in place to expand our county premise of leadership. Looked at the populations, no surprises here. The one thing I come out of the population study was the complete universal need of county leadership within their communities along with other leaders in that community. 5,000 plus hospitals in the country, 920 U.S. county hospitals. Wouldn't have known that number. New York's a good example that a major system is county owned. Academic medical centers. 42 states operate 226 academic medical centers. There are 1,377 critical access hospitals in the United States. Where is this all going? Hospital closures, 700 are looking at possible closure. Dissatisfaction with the system. Counties are in the front line of healthcare with those big numbers. 920, 1,377, 26, 700. They all speak to county leadership. Healthcare best practices hinge on serving individuals. Mainstream best practices hinge on satisfying customers. Healthcare system may be a little behind with this in that one view is individuals are on their own and finding their way into, through, and out of the healthcare system. Over decades, we've proven that at the addition of a personal health nurse supported by general information about health and healthcare, and especially tracking interactions between the nurse and their clients, changes the game. Couple that with primary care, who's also compensated a different way for doing relationship management, medical management. That team serves a different way in individuals. And when I looked at this, I said, whoa, wait a minute. We have state and local governments in the healthcare business heavily, running academic medical centers, and that we're talking about this interpersonal relationship between nurses, primary care. We're teed up to actually deliver that, probably best done within counties. Dramatic revelation on my part. That last slide seems so fundamental and so revolutionary that I isolated it here. Said, okay, it's personal health nurse, individuals, primary cares. Those are the people that take care of people day to day, year after year. And the healthcare systems are there to treat them when they have medical issues that need to be treated. It seems so fundamental. Healthcare best practices applied to a county population flows very smoothly. It starts with knowing what the best practices are, and there they are codified. It works for a county that's 1,000 people, 5,000 people, 100,000 plus people. The needs in the population are the same, and it starts with being a member that's smoothly attached to health and healthcare. Information that's basic data and interactions between the individual and their personal health nurse, with relationships knowing where the members go in return for their treatment. And that is a very low cost, low risk next steps in a county pursuing best practices of healthcare. The other practices can be applied as needed and would become very critical to large counties. Your first thought's got to be, Harry, you're telling us we got to run our own health plan. We can't do that. It's impossible. People go broke doing that. When we start on the finance side, which is number 3, when people start with finance, they nearly always get in trouble. If you start with the individual, you can make it work. So here's my thought process. All hospitals have large Medicare and Medicaid populations. Those populations aren't going anywhere. The Advantage plans and the Medicaid MCOs are struggling, and they struggle because they're in a flawed system. Critical access hospitals, 1,377 as I recall, substantially benefit their members and their sponsoring organizations through Medicare and Medicaid if they use healthcare best practices. There's something very magic there, and I hope that we get a chance to pursue it together. Thanks for listening.